I'm honored to introduce Tammy Weppelman, the State Suicide Prevention Coordinator at the Texas Health and Human Services Commission. Prior to joining that state department, Tammy worked in crisis services at Denton Mental Health, a community mental health center in the Dallas-Fort Worth area, where she served as the administrative team lead for implementing zero suicide from 2012 to 2019. Since 2019, Tammy has worked with behavioral health care providers in Texas to successfully implement the zero suicide protocols, such as universal screening, gatekeeper training, risk assessment and safety planning procedures, and improved transition practices with stakeholders. Tammy is joined today by Mike Olson. Excuse me. Mike represents My Health, My Resources of Tarrant County, one of the organizations currently implementing zero suicide in the great state of Texas. I would like to thank Tammy and Mike for supporting our efforts here in Tompkins County, and I would like to turn this over to Tammy.
Good morning, everybody. Thank you for being here. As Scott mentioned, he reached out to me as somebody who's had experience, boots on the ground, implementing zero suicide, to talk about some tips and first steps to help individuals who are looking to implement zero suicide, because obviously it's a really big task to undertake, and taking those first steps and initial chunks can be key in implementation. And so that's why I'm here today. As he mentioned, I'm going to go through the elements one by one, and after each element, kind of pause and let you have a chance to ask questions or make comments, so that way we don't get all the way to the end and you forget what we talked about at the beginning, because again, it is a huge process, right? And I asked Mike to join me today because, as Scott mentioned, I left the boots on the ground implementation in 2019, right before the pandemic. But Mike represents a center that's currently in the throes of implementation and has been successfully implementing zero suicide during COVID. And so that is a different kind of a thing to be doing, is trying to implement these procedures in a different world. So he definitely has a different perspective on implementation than I bring. So I wanted him to be able to share some of his experiences as well. So that's what we're going to do. I'm going to share my screen so I can share some slides, and then we'll get started. Okay, is that showing okay? Can y'all see the slides? Okay, perfect. So I'm gonna just go on. I always start every presentation I do about suicide prevention with a trauma-informed disclosure. So we are going to be talking about suicide today. That can be a distressing topic for individuals. So please make sure that you take care of yourself during the next 2 hours. Take a break as you need. Definitely send us a private chat if you need to speak to somebody, or call the National Suicide Prevention Lifeline at 1-800-273-TALK if you need to speak to somebody over the next couple of hours or throughout the day. So as you all probably know or have heard, there are 7 tenets to zero suicide, and we are going to go through those one by one today. Tenets are lead, train, identify, engage, transition, and improve. So over the next 2 hours, we're going to break those down into what zero suicide says about each of those tenets, and then small first steps that you can take to implement each of those tenets or elements. So the first one is lead. And so the lead element is really about the creation of a culture in your organization that understands that suicide is a core function of the organization. So suicide prevention, I should say suicide prevention, is a core function of the organization. It's everybody's business. everybody is responsible for suicide prevention within your organization. That suicide is preventable, just like Scott led off with saying that everyone, we can prevent suicide. And the culture in your organization is a just culture, which means that you look at suicide as a system failure rather than an individual failure. So it's not an issue with a specific clinician or something that one person did that led to someone dying by suicide, but they're collectively as an organization or as a system, what can we do better to prevent suicide? And that you're constantly striving for excellence in care in your organization. So some things, some tangible first steps, and we're going to talk about what these look like in our organizations as well. Having an implementation team is really important in the organization. So what that means is having folks from different departments within your organization coming together and talking about what does zero suicide look like in our organization. And that includes having passion and power. And the passion comes from people who are really passionate about suicide prevention. Sometimes those people are direct care workers, and sometimes those people are people in leadership, but it's important to have people who are really passionate about suicide prevention. And then the other part, the power, are the people in leadership. So your implementation team does have to have people on it that can make decisions. So when your leadership team has some ideas or decisions to make, that they can be made during that meeting or during that time. Doing an organizational self-study. So the Zero Suicide Institute has a form that is called an organizational self-study that just asks questions about what are you already doing as an agency to prevent suicide and what are you missing. So getting together with folks in your agency and asking those kinds of questions, going through that checklist. Suicide care policies obviously provide direction, having information about, what are we going to do specific around screening or safety planning or other things. And then communicating to staff means that those things that I talked about on the previous slide, that suicide prevention is a core mission of our agency, and that it's everybody's responsibility. How do you communicate that to your staff? How do you teach staff that even if they are not a clinician, even if they are not somebody with credentials, maybe somebody like a custodian or a front desk employee, that even they have a role to play in suicide prevention. And so how is that communicated to your staff? So I'm going to ask Mike to kind of talk a little bit about how he has seen some of this play out in his organization.
Well, thank you, Tammy. So that implementation team is really a key part of Zero Suicide, and it's a team that really needs that diversity that Tammy sort of spoke to, having experts from different areas in your organization. From everybody from frontline clinicians, administrators, people in IT, people in HR, people on your executive leadership team, if you have something like that in place. So that's really key in order to make decisions to really push this initiative as an organization. And also, I think it's really important to include peers in your implementation team and process as much as possible. We have several peer specialists on our implementation team here in Tarrant County, and the feedback and experience that they're able to share is really it's impactful, number one, and it's really helpful to gain that perspective from them to help really drive the initiative, throughout different parts of the organization. And that organizational self-study is, really helpful as well as one of your first initial steps to understand where you're at. And, if you're a larger organization like we are here in Tarrant County, there's I've been here for 8 years, but there's lots of different programs and initiatives and things going on in the agency that I'm not even aware of, right? So that's another reason, why that diversity and multidisciplinary team is so key and so helpful in the context of zero suicide. And, once you get together as a team and do that self-study, it will really help kind of foster some discussion about where you're at and where you want to focus on next. Because the thing about the zero suicide framework is it's not a perfectly linear process, and there's no exact roadmap to successful implementation. There's a lot of things that come into play, such as the size of your organization, the populations you serve, whether it's primary care, behavioral health care, et cetera. So that's really key to getting this off the ground, is coming together as a team, figuring out where you're at, and kind of creating your own roadmap that's specific to your organization. The next bullet point on the suicide care policies. I mean, we all have tons of policies and procedures at all of our organizations, right? And it's key to have that in place to really increase the buy-in and show that it's not just an initiative that your organization is working towards. It's a part of your how you provide care and how you do business on a daily basis. And the last part, communication to staff. So there's a lot of ways to really get the word out, about this initiative to your organization. For us, one of the things that we do is we have actually a daily agency-wide newsletter that we do, where it's just a one-page newsletter with a couple of different sections to provide updates about things that are going on in the agency, share about resources, things of that nature. So we like to, when we first started implementing zero suicide, we would kind of start with some just general information about the initiative, like, hey, we're going to start implementing zero suicide. This is a little bit about what the framework looks like. And these are some things to be kind of on the lookout for going forward, such as our policy changes and upcoming trainings and different things that we're doing. And so we try to make it a point, our implementation team does, to really, at bare minimum, provide a quarterly update, but really we strive to provide updates more of on a monthly basis, or sometimes even twice a month, to really make sure that this framework and suicide prevention is always on our staff's mind and is at the forefront of what we do. And then, of course, webinars and trainings, continuing education about suicide prevention and this framework.
So obviously, lead is an important element, having this as a core cultural shift. But we want to see what questions you all might have about either the element itself or the first steps, or about implementation, anything that you all might have before we move on.
I'm not seeing any questions so far, but if you have any questions, as Tammy said, about this first element of zero suicide model, please put them in the chat now. Give it a few seconds and then we'll move on to the next element, I guess, if there are no questions about the lead element. Tammy, do you want to go ahead with the second one? And if anyone if anyone comes with a lead question, we'll come into that with the next round of questions.
Sure thing.
All right, so on to our next element, which is train. And as we continue to go through all of these elements, you will see kind of how they're all interconnected as a part of the framework. And they're not in any particular order. Also, I wanted to mention that you know, lead is is kind of a logical place to start, but I mean, they're all important though, right? You can't only do the lead element without doing the train element, right? So they all sort of combine to push the initiative. So training is really just building the capacity of your workforce on suicide prevention practices. So another thing about Zero Suicide Framework is really it gives you the flexibility to pick which trainings you want to use at your organization. Really, the key that the framework mentions is that the trainings must be evidence-based. And you'll probably hear us use that term a lot because you do get to make those decisions on your own, which again is why that implementation team is so important. But the key is just that it's a evidence-based training. So you know, this will help you know, the basic skills for identifying suicide risk and you know, intervention as well, whether that's safety planning, whether that's some of the more intensive interventions that we'll get to in a little bit, but just making sure that especially your direct care staff or your frontline staff is, you know, number one, competent in suicide prevention, but also confident in their ability to identify suicide risk and respond to that risk appropriately. And another one of the keys about the training element is really is making sure that the training that it sticks with the staff, right? That we're not training people just to check it off and say that we conducted this training, but we're having refresher trainings as well. And we are, you know, coming up with a training plan specific to staff's role. Because the framework says that basically your entire organization and workforce needs to be trained on evidence-based suicide prevention practices. But of course, you know, someone in accounting is not going to need the same amount of training as someone in that's a counselor or clinician. So for someone that is not in that kind of direct care or patient-facing role, they still need some type of gatekeeper training, so they at least know how to help out in a crisis situation, because you never know when that's going to happen, right? Like a crisis could happen at your administration building, or it could happen in the parking lot. You never know when and where it's going to happen, right? So for people that aren't clinicians, you know, the expectation is not that necessarily that they'll be able to do a thorough risk assessment and be able to, you know, do a detailed safety planning and things that we would expect from a clinician. But we would at least hope that they have the basic gatekeeper skills to identify that they're at risk and at least help de-escalate that situation and get the person to the appropriate help, whether that's the National Suicide Prevention Line or a crisis line, et cetera. But just making sure that they have some type of skills to be able to intervene in crisis situations. So for the direct care staff, they're of course going to have a lot more intensive training. Here at our agency, our direct care staff is going to get training on how to identify identify risk through screening, and also how to do further assessment if a person screens positive for suicide. And also some of the suicide specific interventions that we're going to get into in a little bit, such as CAMS is the main one we use. So our direct care staff is getting trained in CAMS intervention as well. And safety planning is another one, as well as counseling on access to lethal means, or CALM, which is we've kind of combined that into our safety planning processes. So our next slide here is some first steps to take on this training element. So there's another survey that the Zero Suicide Institute has available to help you with this. That's called the Workforce Survey. So this is something that was helpful for us, and is something that's helpful to do on a regular basis throughout your implementation of Zero Suicide. I believe the Institute recommends to do it at least every 2 to 3 years, but we've set a goal really to do it on a yearly basis. And excuse me, we're actually getting ready to do another one, hopefully here in the next month or two. But when we did our first one, it was really helpful to gauge where our staff was at, how confident they were in their ability to identify suicide risk and respond to it, and which trainings were helpful, and which trainings we needed to kind of push more. So once you do that workforce survey, the state, Tammy and one of her colleagues at the University of Texas in Austin also gives us a report that's really helpful, that compiles all of the data and gives us a good idea of where to pivot to next on training. And next step, dividing the workforce into separate categories. So again, depending on the staff's role, whether they're direct care staff or administrative or leadership, and which population they work with, is another good way to understand where you're at as far as training. And the last one, identifying useful trainings for your agency. So like I mentioned, Zero Suicide doesn't say that you have to use the counseling on access to lethal means training, or that you have to use the Ask About Suicide to Save a Life training, or that you have to use the assist training. So it's really what your agency chooses to utilize. But when it comes to suicide prevention, more training is always better, in my opinion.
I would just add to this that train can be a really difficult element for some agencies, because some of the trainings can be really expensive. And so it can be a challenge to be able to navigate that within a system. So looking for opportunities for grants to find trainings, and then also really looking for training opportunities that can be free. For example, the counseling on access to lethal means, there is a 4-hour in-person training that you can have people trained to provide, or you can do a 1 hour, or I think it's maybe 1.5 hours online training for free. So, of course, the 4-hour in-person training is wonderful and maybe a little bit better because you have the opportunity to practice and do role plays. But with the option of doing if the option is nothing or 2 hours online free, then choose 2 hours online free. So those opportunities are out there. It does take some digging sometimes. So I think this element is one in general that take a little bit more effort because of having to apply for grants to get money to provide trainings, because the trainings are expensive and difficult to get sometimes.
Yeah, the funding is definitely is a huge factor, and also the size of your workforce, of course, when you're talking about training the entire workforce. Because here at my center, we have kind of our average workforce is about 2,000 employees. So, trying to coordinate those trainings for that many people, can be stressful and a little bit of a headache. So, actually sometimes for the training element, being a smaller organization can be helpful, because that allows you to get everybody trained quicker, right? So a lot of things to keep in mind with training, but again, the key is just that you're using some type of evidence-based training for suicide prevention for your entire workforce.
Right. And yeah, training, and of course, turnover can be, I know Mike and I are both community mental health, from community mental health. So turnover is high. So just when you think you're making progress in getting your entire workforce trained, then a lot of people leave and then you have to start over, right? So, and again, that's money going into these trainings. So it's definitely a difficult one to master. And I would also just say that the workforce survey, I know Mike talked about it, it's extremely helpful. I can send the link to the survey if you all don't have it, but it is on the Zero Suicide Institute Toolkit website. Extremely helpful to provide that to your staff. Because I know, coming from the Community Mental Health Center, I thought that we had really great training. We weren't using necessarily evidence-based training at the time before we started implementing Zero Suicide. But one of the very first things we did was this workforce survey. I was like, oh, our training's pretty good. I'm sure people will feel comfortable and confident. And I was completely wrong. The workforce was like, no, I mean, mostly obviously we had mobile crisis outreach and those staff felt comfortable providing intervention to suicide, but not our case managers, not our nurses, not other people who I had received some training and I thought would feel comfortable. They did not. And so it was kind of really eye-opening to me that the training I thought was good was not as good as I thought. So, and so I think that's really helpful and knowledge is power, right? So you really know where, what staff to target training to.
Yeah, and I meant to mention this earlier. This is actually probably more of the lead element than the train element. But one of the things that we're working on here at my center is actually implementing Zero Suicide into our new employee orientation. So it's something that is a work in progress. But kind of the goal will be to at least give them our new employees in the onboarding process some type of exposure to what Zero Suicide is, and at least maybe highlighting some of these elements. So that's not necessarily going to be an evidence-based training. It would be like me or somebody from our implementation team doing a presentation maybe similar to this one to the new staff. But if that's something that you're able to implement at your organization, that I think would be a great idea.
Does anybody have any questions so far on lead or train?
There's a question here I'll put. Have any institutions had any success embedding these as mandatory trainings through HR as a part of onboarding or annual requirements of employees versus standalone trainings offered throughout the year? The SUNY, that's the State University of New York, offers free QPR training. We would like more employees to take advantage of this.
Great. Yeah, so when I worked in the community mental health center, we had so Texas took QPR and made a training that's specific to it's the Texified version. Texas likes to have Texas versions of things. I'm sorry. But so ask is the Texified version of QPR. So if you hear us referring to ask, that's what ask is QPR for Texas. But so we embedded ask into our onboarding. So individuals took that as part of new employee orientation. And they also took the counseling on access to lethal means and safety planning intervention. So those three were required as part of new employee orientation for, well, ask was for everybody, like every single body, and then calm and safety planning intervention was for anybody who would have contact with clients. So they didn't, it wasn't like accounting or HR didn't have to take it, but like front desk and any other people that would have contact with clients, like case managers and nurses and doctors and everybody else. Mike, I don't know how you guys are doing yours.
Yeah, I was going to say, for us, the mandatory trainings, at least as of right now, is really specific to our direct care staff on the behavioral health side. So we do have an agency-wide training plan that our implementation team has came up with, where we sort of divided it up into 4 to 5 different tiers. Depending on staff's role and kind of going from most intensive training to less intensive training. But again, since our workforce is so huge, we have kind of decided to roll the training plan out in different phases. So right now, the mandatory trainings really only applies to that direct care staff in our behavioral health side that is actively managing a caseload or is a part of our crisis services department. But hopefully we will at least have ask about suicide to save a life or some of the basic gatekeeper trainings required for everybody. But that just is going to take some time due to the size of our agency.
Another question, can we talk more about peer involvement and what that means?
Sure. So for the in the lead element for implementation plans, or sorry, implementation teams, it is encouraged to have individuals with lived experience on your implementation team to help steer or guide your implementation. And an individual with lived experience is defined as somebody who has lived experience with suicide thoughts, attempts, or something like that, or an individual with lived experience with a suicide loss. So either or both of those things. Sometimes I know, like Mike mentioned peers, and I can let like their peer staff, so I can let him speak to that. But when I was at my community mental health center, we had an individual who was not a peer staff, but who was a client who was an attempt survivor on our implementation team. And then we also had a staff member who was a loss survivor on our implementation team. So those were our individuals that with lived experience that participated on our team. But it's really important to have people with lived experience because they just see things with a different lens and can provide different input than just, our everyday clinicians who just, it's just a different lens. And so being able to say, I really wish that on X day, my loved one had this experience or that experience, or, when I was in the system and I had thoughts of suicide, I didn't get this or that, or, it's just a different, perspective, and keeps things, it just keeps things rolling. So, Mike, I don't know if you want to talk specifically about your peer providers.
Sure. Just like you said, that peer support perspective has been really so valuable to us. And as far as the lead element, the peers have been helpful to me. Actually, just recently, there was a situation where we were reviewing some of our operating procedures and policies related to zero suicide, just to kind of capture some updates and changes that we've implemented since the last time that we worked on that operating procedure. And I was really glad that peers were involved in that discussion, because I took kind of a draft version of that operating procedure to them and asked for some feedback, right? And the feedback they gave me, it was amazing. It was things that I hadn't thought of and things that I hadn't considered, where they were kind of saying, well, this wording, it could be more person-centered, or, it could be more trauma informed, not that it was necessarily wrong, but hey, here's a way that we can do this better, to where it doesn't sound like, for example, that we're punishing patients that are at high risk for suicide by seeing them more frequently or assessing them more frequently. It's more about keeping them safe, and really framing zero suicide as strengths base for the patients that are in our services, and the way that our staff views the initiative.
Thank you. There's another question. Clarify the name of the training for the non-clinical staff that would work for admin assistants and other folks who interface with clients day to day.
We use Ask in Texas, but it's really QPR. It would be QPR for y'all, yeah.
I actually had a question of my own, if I may.
Sure.
I was going to ask Mike, what was your experience with the workforce survey in terms of how your folks felt they were trained, how well trained they felt they were, and how confident they felt they were?
Yeah, so for the workforce survey results, it was kind of in line with what we expected overall, but there were some surprises there that helped us kind of with next steps that we needed to take. So basically the findings were that, kind of, I think, like Tammy already mentioned, that our crisis care staff and our case management staff, direct care staff that sees patients every day on a regular basis, they overall were pretty confident, but really could benefit from additional training. And then people in those non-clinical roles in the agency, they, of course, as you might imagine, did not feel quite as knowledgeable or confident as far as identifying suicide risk or how to respond to it. And another thing that we learned from our workforce survey actually ties back into that lead element and just culture. So that workforce survey really highlighted for us that this just culture needs to be a focus for us. That's where our scores were kind of the lowest. And so we knew which trainings to focus on after getting those results. And we knew we needed to focus more on that lead element and kind of a cultural shift, or improving the culture around suicide prevention.
As you've done more workforce surveys, have you seen tangible improvements in the results?
I've only done just the one so far,
Okay.
but we are going to roll out another one for the second time, hopefully next month. And the other key with this survey is actually getting your organization and your staff to complete the survey, right? We've been wanting to do another one for several months now, but we tried to make sure that we are intentional and strategic about when we release it. Like, for example, this month we had a staff engagement survey going on, so we didn't want to compete with that. And a couple of months ago, we actually we had a outage on our Chronos system, which is our timekeeping and payroll system. Kind of all of our agency communications had been focused on a lot of other things recently, and we didn't want to compete with all of that because we want to get as much participation as possible. With our last one, I think we were right around 50%. I think it was like 48% or something like that. But I'm going to be a lot more intentional this time. We've already kind of, screen went out here.
We're seeing you.
Yeah, we can see you and hear you still.
Okay, that is weird. My screen completely disappeared on me. Lost my train of thought there, sorry. But we've provided kind of some heads up in our agency newsletter that, hey, this is coming down the line, the Zero Suicide Workforce Survey. So just a heads up, we really want your participation and value your participation. So that's going to be released in the coming weeks. And so once it is, please participate. And then once we actually release it, we'll give staff ample time to complete that and kind of provide daily reminders to complete it as well.
Thank you.
All right. So we will go on to identify. So the identify element is focused on recognizing individuals at risk, doing screening and assessment. We want hopefully to do universal screening, so screening every person, every visit, every time. And then for individuals who screen positive, doing a risk assessment, a full risk assessment in a timely manner, same day risk assessment to determine next steps for those individuals. So again, a lot of things go into doing universal screening. Obviously, a lot goes into same day risk assessments, but that's the goal with the identify. So just a few tangible first steps. A lot of just choosing a screener can be a task sometimes. We put the CSSRS and ASQ on here. Some people use PHQ-9 also. I know that's a big one with healthcare. I know a lot of you are healthcare folks rather than behavioral healthcare. The thing with PHQ-9, though, I will emphasize is that the 9th question doesn't specifically say suicide. It says harm yourself. And so that one is a little bit iffy sometimes with suicide prevention folks. So just kind of be mindful of that. We do recommend CSSRS or ASQ specifically for suicide screening. And then determining a frequency for screening. So obviously, again, we really recommend universal screening, but sometimes that's not feasible. Can you do weekly, monthly, quarterly? Like what do you think is feasible for your practice? And at least choose like what is going to be your practice for screening. Sometimes practices will say, okay, we're going to start out with doing monthly screening, and then we'll try to work ourselves up to quarterly. That's at least, we're going to start somewhere and then try to work ourselves up to something. So I think that's really helpful. The great thing about the CSSRS is that they have a since last visit version, which is what we implemented at our agency. And the since last visit version has 2 questions. which are, since the last time we saw you, have you had thoughts of wanting to go to sleep and not wake up? And since you were last here, since we last saw you, have you had thoughts of killing yourself, or, have you had thoughts of suicide? And if they say no, you're done. If they say yes, then you ask the remaining questions, which are about method, plan, and intent. And so the since last visit version was really easy for us to implement in our agency, because again, most people were like, okay, it's just 2 questions. For the most people, most times you're going to ask 2 questions. And then if you get a yes, then you need to ask more questions anyway, right? Rather than a longer screener that, you have more questions with. So that's something that I recommend is the since last visit version of the screener. Whatever screener you choose, having that embedded in your EHR can be a bear, depending on what EHR you use. That may be more of an issue with behavioral health than it is with medical, because with healthcare or primary care, y'all may have awesome medical records with those already embedded, but I know we had some issues with that. I know some of the other community mental health centers in Texas had issues with that. And then really knowing what your next steps are for people who screen positive. So in Texas, we have awesome mobile crisis outreach. So we can say, if somebody screens positive, then our next step is to call mobile crisis outreach. So what are those next steps for you in your area? Because if someone screens positive, there needs to be a same-day risk assessment. So for your area, are you the ones that provide that risk assessment? If not, who is? And making sure that you have those next steps in place. Super important. Because we want to, obviously we need to ask, and when we get a yes, what do we do, right? So those are some tangible first steps to take for the identify. Mike, do you have anything to add from your perspective?
Yes, I do. So this is another one of the parts of the zero suicide framework where you have some flexibility in how you want to do things. So you do get to choose which screener you want to use. But again, the key is just choosing one that is evidence-based. And so for us, we do use the CSSRS screener, and most of the other centers in our area use the CSSRS as well. There's a lot of the reasoning behind us choosing that one. Tammy touched on it a bit, because they have that version that says, since your last contact. But the other good thing about the CSSRS screenings is they have different versions of it for different populations. Like I know they have one that is specific to the youth population. They have one that's specific for IDD or disability services. They have one that I believe is specific to substance abuse. They have is probably 15 or 20 different versions of that screener that you can utilize. So I think that's helpful to have that flexibility with the screener, with all the different populations that are served in behavioral healthcare and primary healthcare systems. And as far as our frequency for screening, basically every time a patient comes into one of our outpatient clinics, they are going to be screened. If they're seeing the doctor, usually the medical assistant will do a PHQ-9 at least. So we use that one as well. But also if it's a intake type of appointment, they're going to get that CSSRS screener. And in the event that they do screen positive, kind of like Tammy mentioned, they're going to get further assessment. And that's actually another reason that we use the SSRS is that there's a full length assessment as well. So we use the screener version to screen for the risk. And if we get a positive risk, then we pivot to the full length assessment where it gets really detailed about a person's really their history with suicide if you haven't seen that full length assessment. But it gets really in the details of talking about attempts, attempt history, when it was, the method of the attempt. It talks about things like, are you able to control your suicidal ideation? Like, how well do you control it? Is it kind of fleeting, or is it completely beyond your control, and that's all you're thinking about is suicide? And then there's a section towards the end where it gets into lethality. So it's a really thorough assessment that we have in place for those that screen at risk. So they get that full length assessment as well as a safety plan. And even for those that screen positive and screen not positive, but there, is maybe some risk involved, they will still get the safety plan, because we've kind of come up with a scoring system for our screener to where if they score 8 or above, then that's going to warrant the full length assessment. And if they score 6, they're not necessarily high risk, but more of like a moderate risk, they will still get the safety planning intervention. And then we do have all of this embedded into our EHR, which makes things a lot easier. If someone else was to open up the patient's chart and review their history, it makes it easier for reporting purposes. I don't know if we're going to get really too much into the zero suicide metrics today, but the frequency of screening and safety planning is some of the key metrics to get to really full fidelity on zero suicide implementation.
A colleague has a question here, but I wanted to ask for clarification on something. So in your bullet point there about frequency for screening, Zero Suicide advocates for universal screening. Isn't that correct?
Mhm. That's correct.
But when you say monthly or quarterly, you mean per patient? Like, how often would you screen a certain patient?
Yes, like there are agencies that implement zero suicide, but they may just do screenings monthly or quarterly to start, and then they move towards universal screening, or they just choose to screen monthly, for example. But zero suicide does advocate for universal screening. Yes.
Maybe I should ask that question. There's another colleague has a question, but let me just follow up with that. What is the value of universal screening? I know that most agencies would do screening, and I think that there's a tendency to focus on people presenting with behavioral health issues to screen them. But why is universal screening needed?
Well, research shows that approximately 50% of people who die by suicide went to primary care within the month before their death, not necessarily behavioral health care. So, and people don't always present with their, like say, I'm feeling depressed, or, sometimes it's, physical issues that they're presenting with, even though it may be a manifestation of depression or whatever. And sometimes people, a lot of times in my experience, people don't come out and say they're having thoughts of suicide without somebody asking them. However, if you do ask, they're most of the time honest, because they just want to know that it's a safe place or a safe person to talk to. So the benefit in universal screening is that if you ask, you're going to catch people, and if you don't ask, you're not. So yeah.
So if I go to the emergency room for a broken leg, I should still get screened for self-harm or suicidality.
Correct, because you don't know unless you ask, right? I mean, just because you broke your leg doesn't mean you're not having thoughts of suicide, or weren't when you broke your leg, or haven't been having thoughts. The broken leg is neither here nor there, whether or not you were having thoughts of suicide before or whatever. Yeah,
And a colleague is asking, do you do the CSSRS for all patient visits?
yes. So well, I'll let Mike answer, but when I was doing community behavioral health, every visit, every person, every time. So if someone came in to see the doctor, if someone came in to see their case manager, and as I mentioned, we did the since last visit version. So we would say, since the last time you were here, have you had any thoughts of suicide? Have you had any thoughts of wanting to go to sleep and not wake up? So there's 2 questions. And if they said yes to either of those questions, then we did the longer screening version, which is 6 questions. But if they said no, then we would just document that they didn't, they said no and went on. But every visit, every person, every time. So.
Yeah, that is our goal as well. To be honest with you, we aren't there yet, but on our behavioral health side, yeah, I mean, when someone comes in for an intake, they're going to be screened. If it's a follow-up, they're going to be screened and assessed. As far as the frequency part, and we'll talk about this when we get into the care pathway piece of zero suicide, but for those that are at risk and we put them on this pathway, they're going to get weekly screenings done by our case management team. So they would actually, they're going to go out in the community on a weekly basis and see that high risk patient and engage them in safety planning and screening. And hopefully that's, is not a service that's going to dominate their treatment plan or their wellness plan. The screening and safety planning is, I mean, it's crucial to zero suicide, but it's put in place to keep them safe, right? So, in theory, hopefully the patient is engaging with the treatment team and, having a decrease in their suicide risk by engaging in services. And you're basically just monitoring that risk by screening, keeping the patient safe, and then you're moving on to working on that person's goals, whether that's housing or finding a job, whatever their goal is still going to be kind of the driving factor of their treatment. But we have to keep them safe, right? If we lose someone to suicide, then that's the worst outcome as a treatment provider, right? So, we always just have to monitor for safety.
I've heard somebody say, like, I can't believe, like, it seems like a lot. Like, what if somebody comes in every week? You ask them every week about suicide. And I'm like, yes, it's just kind of like every time you go to the doctor, you get your blood pressure taken, you get your temperature taken. And asking about suicide is like a mental health vital sign. So those are your physical vital signs, and asking if you're having thoughts about suicide is a mental health vital sign. So that's the way that's not mine. I can't remember who said that. So I'm sorry, I can't give whoever it was credit, but so we get our physical vital signs, we get our blood pressure, we get our temperature, we get our pulse and our O2 or whatever, but then asking about are you having thoughts of suicide? Have you had any since the last time I saw you? What about thoughts of going to sleep and not waking up? Those are our mental health vital signs, and then we move on with our appointment. So those, I think that's the way that it's really important to think about it that way. So it's not like, oh, we have to impose on this person again. It's just our mental health vital signs, and then we're moving on.
And just remind you, Tammy and Mike, you have 45 more minutes just to space out the rest of your presentation. Okay. And I also want to ask anybody who jumped in who hasn't signed in with the chat with your name and affiliation, if you could do that, please, if there is anybody. Sorry to interrupt.
Nope, you're good. We'll go ahead and jump into engage. You gonna take this one, Mike?
Yes, I was just I was just going to chime in and say I'm not sure who came up with that analogy either with the vital signs, but I've used it and I think it's a great analogy, and it kind of highlights, when someone comes in and we're checking their vital signs, we're almost doing it without even thinking about it, right? It's just kind of routine. We're not doing it because a certain initiative says it or whatever. Obviously there's medical liabilities, but that's just the way we do business, just a normal part of it. So yeah, I think that that's a great way to look at it. So the next element is the engage element. So this one focuses on engaging individuals in care that have been identified as high risk for suicide. So here it talks about a suicide care management plan. You will hear a lot of times within this framework, you'll hear that referred to as the zero suicide care pathway. Here at our center, we're calling it the clinical pathway. But this element, it does rely on policies that you've outlined, that your implementation team has outlined. And of course, this ties into training as well, because your staff have to be well trained to be able to engage these high risk patients in care and in services. So that suicide care management plan is going to include basically a higher level of care or more intensive wraparound type of services. So there's going to be ongoing risk assessment and screening as a part of that plan. Now, for us, we do that for people that are at high risk. They are going to get seen at least once a week face-to-face, and another contact over the phone. It's kind of how we've been doing things during the pandemic. But I think the framework actually says that really the people need to be seen face-to-face every 3 days, if at all possible. And so again, when those patients are getting these follow-up services, screening for risk and safety planning if needed, and then really going on to engage them in their treatment plan, whatever that looks like for them. And I think that we can go on to the next slide. Yeah, there we go. So some first steps here. Number one would be to choose an evidence-based safety plan. So for us, we use the Barbara Stanley safety plan, and I think that one is a pretty common one that I've seen a lot of other agencies use. I'm sure there's plenty of other options, but honestly, I'm not too familiar with the other options. But I know for us, the Stanley safety plan has worked really well. And one of the reasonings behind that is because as a part of that safety plan, there's a section where lethal means is addressed. So, when you choose that version, you're almost safety planning and counseling on lethal means within the same plan. Next step would be determine procedures and protocols around how you're going to use that safety plan. So, this is something that is going to be probably determined by your leadership and your implementation team when they're coming up with workflows. For us, really the goal is that the safety plan will be reviewed at least at every interaction with that patient, and changed or revised as needed. Next step would be determining procedures and protocols around this care pathway or care management plan. So things like how frequent the follow-up visits are going to be, and the criteria for getting on this pathway, as well as being discharged from the pathway. So for us, we have made this this pathway an optional service. We do not force patients to get on this pathway, but we do have that conversation with them, in a very person-centered way that, hey, we would like to see you more often, and maybe, provide you with extra resources and extra services. And in doing so, we're gonna, we just want to keep you safe. So we're gonna, be seeing you more frequent, and we're gonna be, reviewing this screening and safety planning throughout the course of our follow-up visits. And so for us at our center, for people to basically qualify, I guess, for this this pathway or be identified as high risk, that's going to be 8 or higher on that CSSRS. And so at that time, we would offer them the care pathway. And we decided as an implementation team that we want to keep those patients on the pathway for a 1-month minimum. So, of course, sometimes a person's suicide risk could, could decrease all of a sudden, or maybe the clinician didn't do a good job on the assessment, or, the patient was having a bad day, something like that. But when we see a high score, we want to keep them on for at least a month. So, we can keep monitoring those vital signs and, ensure their safety. And on the other end, these pathway services, for us, the max is going to be a year. Normally, for most patients, they're going to fall somewhere in between that range, something like 3 to 4 months, because generally, if someone is still screening and assessing as high risk, say 7 or 8 months down the line, even after receiving this higher level of care, then, to me, that kind of says that something's not working, or, something needs to be changed. Something else is needed as far as treatment. But we do give them the option to stay on there for up to a year before transitioning them to a lower level of care. And the last step is determining your procedures or protocols for missed appointments. So for people that we have on this pathway, they anytime that they miss a scheduled appointment, our staff is going to go into our missed appointment protocol. So they're going to try multiple phone call attempts throughout that same day of the missed appointment. And if they still can't get an answer, they're going to contact the person's collateral to try to verify safety. And if that doesn't work, eventually they move on down the line to a welfare check by the police department. So basically, that's all going to take place within 24 hours of a missed appointment if we can't confirm safety.
So I think the only thing that I would add to this is that this is another element that is one of the more difficult ones to implement. I think the care pathway typically, I think, gets people and makes it, and people find it really difficult to implement. I do think, though, that for the most part, agencies have procedures or policies or protocols for how they work with individuals who they deem higher risk. And it's just this term care pathway makes it seem like, oh, it's this big thing. It's really not. It's just really, the care pathway is what are you doing for people who are higher risk? And so, and then it's putting them in a group, I guess. So just kind of think of it that way, because I think a lot of times having this term care pathway makes it feel like it's bigger than it really is. What it really is providing those services to individuals who are higher risk. And so I would just keep that in mind. But this element itself is not one of the lower hanging fruits. Definitely, I would say the identify one is the safety planning piece can be a lower hanging fruit, but the engage element in and of itself is probably a little more complicated. Any questions?
I have a question. Am I correct in assuming that whether a patient would want this care pathway, which involves a lot more commitment on their part, perhaps, whether or not they want that, you would have everybody walk out of an appointment with a safety plan? And could you actually tell folks who may not be familiar with the Brown Stanley safety plan, what is the plan? What does that involve?
Sure. So the Stanley Brown Safety Plan is a stepwise plan that goes through helping individuals from starting with identifying their triggers and then walking through internal coping skills and kind of trying to self-soothe all the way to reaching out to professionals for help, which is a way for them when they're having thoughts of suicide to distract themselves from that and keep themselves safe until like those thoughts either go away or they're able to get to help. So there are 6 steps on the safety plan. It starts with here are some internal coping skills, then who can I reach out to distract me, or where can I go to distract myself, to like your internal support system, so friends or family that you can talk to for help, and then professionals you can reach out to for help. And as Mike mentioned, the last step is means safety. So what do you need to do to make your environment safer? And then some safety plans have like a reason for living listed on it so that people can remember their reasons for living. And so, yeah, the safety plan, the Barbara Stanley is, or the Stanley Brown, as it's also known, is probably one of the more commonly used safety plans. Craig Bryan also has crisis
response planning.
Thank you. Crisis response planning, which is another evidence-based safety plan that is used pretty frequently as well.
And would you have every patient who's identifying as at risk or assessed as at risk at least go out with a safety plan, if not commitments for follow-up appointments, et cetera?
Yes, yeah, everybody will do a safety plan. Mm-hmm.
Yeah, if there's any type of risk at all, if they're moderate risk, they're still going to get safety planning. Unless there's absolutely zero risk, they get that service.
Okay, thank you. No more questions.
Okay. So the treat element is talking about evidence-based intervention specific to reducing suicide risk. So in the past, we would focus on reducing thoughts of suicide by treating the DSM diagnosis associated with the suicide risk. So in other words, we would say if we decrease the depression or the bipolar disorder symptoms, then we would decrease the suicide risk. Zero Suicide says that there are specific treatments that we can use to help an individual decrease their suicide risk apart from any mental health concern. So this element says that we're going to focus specifically on suicide specific treatments to decrease suicide risk apart from anything else going on. And so we're going to provide individuals with at least one suicide specific intervention and document their results. So there are 3 suicide specific treatments that are recognized by the Zero Suicide Institute, which are collaborative assessment and management of suicidality, also known as CAMS. That comes out of the David Jobs clinic at Catholic University. There is dialectical behavioral therapy, which is Marshall Linehan. People are probably a little more familiar with. And there is cognitive behavioral therapy for suicide prevention, which came out of Aaron Beck's clinic, a sister to CBT, but there is a specific cognitive behavioral therapy that has been developed specific to treating suicide. So it's CBT, SPs, or cognitive behavioral therapy for suicide prevention. So again, I mean, the first steps would be to determine what, if any, or what suicide specific treatments you could use in your agency and the cost associated with that, or even maybe you could contract those services out from your agency. I know at our agency, we used, we had individuals trained in all three, but we used mostly CAMS, or Collaborative Assessment and Management of Suicidality. DBT and CBT-SP require counselors, like therapists, whereas CAMS can be provided by non-licensed individuals. And so it is easier to provide. It's also a little bit more cost effective to provide CAMS, and CAMS can be, the training can be done online. So there is still a significant cost to it, but it's less than the other two trainings, and it can be done online. So case managers or care coordinators or any of those types of individuals in your organizations can be trained in CAMS and can provide that. And CAMS there's so much research done on CAMS. David Jobs is very much on top of doing research and for his model. And he has shown that it can be effective in as few as 3 sessions, although more effective in 10 to 12 sessions. But basically what collaborative assessment and management of suicidality is that the individual working with the person with thoughts of suicide helps the person to identify what he calls suicide drivers, but it's really reasons for dying. And helps people to talk through their reasons for dying, identify reasons for living, and kind of get to the other side of their reasons for dying in a nutshell. It's somewhat complex, but again, can be pretty effective in as few as 3 sessions. So we found it extremely effective in our behavioral health organization when we used it. But again, all of these can be a little bit pricey. Mike, do you have any additions?
So for us, we are using the CAMS model for treating high-risk patients. Now, this is another element where it's about figuring out which one of these options works the best in your organization. So for us, CAMS is the best choice due to the number of staff that we have and the number of patients that we served. But we love the flexibility of CAMS. Like Tammy mentioned, it does not have to be a licensed staff that provides it. And I mean, even peers, I think, could use it in theory. There probably would be some some debate on if that's best practice or not, since it is a little bit of a clinical intervention. But I also love it just because of the collaboration between the clinician and the patient, and the way that it just really dives in to talk about suicidality directly. You know, I love the patient involvement and kind of the way that this intervention actually works and how it looks. If the pandemic was not a thing, I've seen it kind of modeled by the CAMS trainers, that basically the clinician and the patient would sit side by side, instead of kind of the old standard where the clinician's on one side of the desk and the patient's on the other side. Instead of that, we're sitting side by side, and the things that we're putting on the CAM stabilization plan, which is one of the key components of the intervention, is it's up to the patient. The clinician is there to guide that stabilization plan and provide feedback on the plan and their reasons for living and reasons for dying if the patient can't think of any reasons. But and it's of course up to the clinician to make sure that the risk of suicide does not reach kind of a urgent level to where hospitalization is needed. But I think CAMS is a great choice. It was what works best for us, and we are actually in the process of getting our direct care staff trained in CAMS at the moment. So we have some staff that have been trained in it, but training is still ongoing for that one.
Thank you.
Any questions?
No questions on this slide.
All right. Moving on to transition.
Okay, the transition element. In my opinion, this actually is probably the trickiest one, at least for us. But this element focuses on your organization's capacity to manage any suicide risk during care transitions. So this includes things like when patients are transitioning from the hospital, or whether it's an inpatient visit or an ER visit kind of thing, making sure that there's some type of follow-up, to that crisis situation. Supporting individuals that miss appointments or are not engaging in care. Like I mentioned a couple slides ago, we do have that missed appointment protocol, but the services are optional. We can't force patients to engage in services if they don't want to. So there's things that the Zero Suicide framework has in place for kind of re-engaging those individuals that withdraw from care, such as caring contacts. And so that's something that we are working towards implementing as well. So that's really just very basic correspondence there, just saying, hey, we haven't seen you at the clinic in a while, sending them a letter in the mail. We haven't seen you in a while, and we're here for you if you need us, and just including contact information, that way they can reach out if they'd like to. And then the last bullet here, supporting individuals transitioning to a new provider, whether that's another program inside your organization or another organization altogether. So really just trying to facilitate a warm handoff, so to speak, to make sure that that patient doesn't fall through the cracks during that transition period. Couple of first steps for the transition element, number one would be to identify key stakeholders in your community. And this is, in my opinion, identifying those and establishing the relationship with those is, probably the most important things. For us, it's a little bit of a challenge in in Fort Worth because it's such a large city, and we have a really good relationship actually with our local county hospital. We have actually staff from our agency that are officed out of different areas of the local county hospital. So, for example, we have liaisons in our psychiatric emergency room. We have them in the or some involvement in the medical ER side as well, and the inpatient unit also. So, they are able to do things like schedule a follow-up appointment before that patient is even discharged from the hospital. Whether that person is already in our mental health services or not, they're able to go ahead and get them enrolled if they're not already, get them scheduled with the follow-up appointment, and also making sure that follow-up appointment is ideally within 7 days, right? Because if someone's being discharged from the inpatient setting, they need to be seen sooner rather than later. And so for us, we kind of use the CCBHC model for care transitions. So making sure there's timely follow-up after any type of discharge from the hospital. But one of the challenges with this is the other hospitals in the area, the private ones, for example. So we don't have relationships necessarily with all the private hospitals. And so there may be times where a patient goes there, for whatever reason, and we just plain don't know about it. And if the patient doesn't report it, honestly, sometimes that interaction may be missed entirely. And so that's just one of the challenges, that there's so many private hospitals around here. And also, if you go about 20 miles down the road, then now you're in Dallas County, and it's a whole nother system of care. And then we have Denton County, about 20 or 30 miles in the other direction where Tammy's from, which is, again, another area of organizations. And so those are some of the challenges, but it's a lot of work to sort of solidify your care transitions, but it is a key part of zero suicide, because that is really a lot of times where a patient is most vulnerable.
I'll just add, so what we did in Denton was, we're a smaller community than what Tarrant was, probably a little bit larger than what you all are still, but we had, I think, 5 emergency departments, so medical hospitals, and 3 psychiatric hospitals in our county. And we, as the community mental health center, established MOUs with each one of those facilities to say, if you have somebody that comes in, for the psychiatric hospitals, it was, there was an MOU that if somebody came in and was discharging, that needed a psychiatric follow-up for outpatient services, they would be direct drop to our door, so that we would immediately, I mean, obviously within an hour of discharge, we would be seeing them. And then for EDs, for somebody that came in maybe for a suicide attempt, our mobile crisis outreach would be called to the ED, so we would be doing an immediate follow-up. And then for anybody that maybe was just in the hospital for suicidal ideation or would need a follow-up, the EDs would call us prior to discharge to set up a follow-up appointment. And all of that was set up through MOUs. So it seems like in y'all's community, I mean, there's so many people here from so many different agencies today. Hopefully y'all know each other and have some relationships that you would be able to establish some of these things. I think it's really important. Those care transitions are such important times. You know, I can't remember, it's like 273% more likely, individuals are 273% more likely to die by suicide within 30 days of a care transition. Like these times are so super important. So these are some really great steps right here, just to be in communication with each other, who's responsible for what, at what point can we pass off care, and you know, even if it's not, we can't direct drop somebody to your place, can we have a phone conversation before the person discharges so we know they have an appointment, and then it's now, if they don't show up to that appointment, I'm going to call them and I'm going to make sure that they follow up, those kinds of things. So yeah, that would be my 2 cents to add. Any questions?
Can you talk a little bit about how a memorandum of understanding actually works?
Yeah, so it basically just kind of outlines the responsibilities of each agency for a specific event. So in our case, for example, with the psychiatric hospitals, we just said, okay, so an individual is in care, they need to they need an outpatient visit. We're going to, like the psychiatric hospital is going to do this. They're going to call the community mental health center and say this person's discharging today. They're going to agree to drop them off at this location. The LMA, the local or the community mental health center is going to receive that person, is going to intake them into services, and will then ensure they get to where they need to go after. They'll drive them home or whatever. So these were, like, for example, some outlines, and then the CEOs of both organizations signed it, and it was just like an understanding, this is how we're going to operate these transitions.
A question about CAMs. Is it required that CAMs be carried out by a licensed quality health professional only, or can CASACS or CASAC also carry it out?
I'm not sure what those credentials are, what those letters mean, but anybody can do CAMs. It doesn't have to be like a licensed person.
Substance abuse professionals.
Oh, yeah, they can do CAMs as well. In Texas, we have qualified mental health professionals, which is basically somebody with a bachelor's degree, and they are able to do CAMs.
Thank you.
Anyone can do CAMs as long as they are CAMs trained.
Yeah.
Thank you. No more questions.
Okay, well, we will try to zip on through improve, which improve is another really important one, right? So its emphasis is on continuous quality improvement. So you're looking at your fidelity to your different components, and your like, what are you going to measure? How are you going to know that you're doing a good job? How are you going to know that you're implementing zero suicide? And so we have a couple of slides here. So one of the things that you really want to measure when you're talking about improve is deaths by suicide, because zero suicide is really about not having suicides in your system, right? Of course, it's you know, there may be times excuse me, that you do have suicides in your system, but overall zero suicide is about doing everything we can to eliminate suicides in our system. So you want to track how many deaths by suicide are occurring in your system, and also suicide attempts in your system. But that can be really difficult to track. So looking at ways that you can, if you are notified of deaths, how can you keep track of them? Are you able to even know if someone in your system attempts suicide, that those suicide attempts has been one specifically, excuse me, in our system in Texas that we've had difficulty tracking. So are there ways that you are able to track if your patients attempt suicide? And then reviewing the data element worksheet, which Mike referenced earlier, and that is available on the Zero Suicide Institute toolkit, to choose data elements to track and review as an agency. So you want to determine what things that you find important for your agency and actually track them to make sure that you're actually improving on your implementation. So I'm going to show you, Mike said, I don't know if we're going to get into it, but this is the screenshot of the data element worksheet. So these are just a couple of the things that you can choose to track. I believe there's 15 or so different data elements on the worksheet, but you can see here, like, number of clients who received a screening during the reporting period. What's the reporting period? Whatever you choose it to be, maybe a quarter, maybe a month. And then number of clients who screened positive that had a risk assessment, the number of people who had a safety plan, and the number of people who screened positive and had some risk that also you discussed lethal means with as an example. So obviously, if you want to track these, you have to have a way to track them. Do you have a way in your medical record to pull reports on these? So this is just a little bit of a few of the options, but again, the full data element worksheet is available on the toolkit, and you can choose any number of them. And we always recommend start small, choose a couple, 2, 3 elements to look at, and then maybe expand over time. So there's another part of improve is setting an implementation plan for your zero suicide efforts. So some things to consider with your implementation plan, choosing 1 or 2 areas to focus on. So we just went through a whole bunch of information, and if you try to do all of that at once, it will be very difficult, if not impossible. So you know, the little tips for where to start, choose 1 or 2 of those, kind of focus on that, and then move on to other areas. Setting small goals, remembering, like, you can only eat an elephant 1 bite at a time. You can't eat the whole thing at once. So just taking this in small bites. Where are the low-hanging fruits for your organization? So some organizations may have heard something that we said, like, oh, we can implement the CSSRS pretty easily in our organization. All we'd have to do is 1, 2, 3, and it's done. While other organizations are like, oh, wow, that would be so hard. But, you know, we could send an email about how we really want to do this in our organization and start getting staff involved. That would be easy. So whatever it would be for your organization, start there and then kind of work your way from there. Look for opportunities to combine efforts and initiatives. So the one example that always comes to mind, almost all of our agencies here in Texas have had a long-standing trauma-informed care initiative going on in their agencies. They've been trauma-informed care, everything. And then over here, they've had zero suicide. And then they've started to merge those together because they overlap so well. And so if you have another initiative in your agency that kind of overlaps, instead of like running 2 trains at the same time, see if you can work together with another initiative to try to combine efforts instead of like working against each other. And remember, it's a marathon, not a sprint. It's going to take a really long time. And it's a continuous quality improvement process. It's not something, it's not like an initiative that you start today and you end next week. it's always a continuous quality improvement project that you will be working on in your agency. So this one is just a screenshot of the implementation plan that's available on the Zero Suicide website. And it just gives you a little bit of action steps for each element and how to break it up into different quarters. Again, this is just an example of what's available, but just giving you some options of breaking that up. Just considering what you can, what 3 goals you can set over the next 3 days and what you can do over the next year. And I know that we are almost out of time, so I want to see if there's any more questions that have come in.
I do have one question. I don't see any other questions yet, but one of the issues that I think some of our partners in the community have had is sustainability. They were interested in implementing zero suicide, but COVID and other things got in the way. We've had top leadership transitions in a lot of the healthcare provider agencies in the county. Do you have a secret on how to make this a sustainable project within a healthcare agency? It seems that the creation of an implementation team would be the way to do that, because once you have that team, even if some members transition in and out, at least that team would be there and be held accountable for the sustainability. Is that a good idea, or do you have other tricks to make people to get people? They have a lot of enthusiasm to get started, but then it seems to wane or fragment as time goes on. Is there a way to make sure this is sustainable and it doesn't just drop off the radar? Because of course, all these providers have so many other issues on their plates.
Yeah, I'm going to give a quick answer and then let Mike speak, because he's been doing this during the pandemic. But I would definitely say the implementation team is key, because like you said, if people drop off, other people are still there. But one of the very first things I said today is having the passion. So while it's super important to have leadership on your implementation team, you have to find the passion in your organization to be a part of that implementation team, because even so leaders are easily drawn to other priorities, right? But the passion on your implementation team, they're not going to be drawn to other priorities. They're going to keep that team driving forward because their passion is suicide prevention, right? So even if the leaders are like, okay, we really have to focus on this, and that might be true, that there's still passionate people on your team that can keep that team moving forward, even if it's a little bit slower because there's other things going on. That having the passion, having the lived experience folks, those are going to be the people that are going to keep it driving when leadership may have to be focused on other things.